Hello students, today we are going to learn about the polyneuropathy. So the name itself it is telling poly means multiple, neuro means it is related to nervous system, pathy means it is pathology. So the polyneuropathy it means that nervous system is affected at multiple level with some pathology. Let us start with the introduction of polyneuropathy. So what is polyneuropathy? Polyneuropathy it is damage or disease affecting peripheral nerves in roughly the same areas on the both sides of body featuring weakness, numbness and burning pain. So what it is telling that peripheral nerves they are affected by any damage or disease. So generally the features will be same on right side as well as left side, and clinically it will be identified by muscle weakness, numbness or burning type of pain. Now, generally it begins at the distal organs. So, generally it starts with hands or feet involvement. Gradually it progresses proximally. Okay, so it may start involving arms as well as legs. Sometimes it is also spreading to the other areas of the body where it may affect our autonomic nervous system. Now, classification of the polyneuropathy is based on many domains. So, which are these domains? Domains are mode of onset, functional disturbance, pathological process, causation, so that is nothing but etiology, and distribution of polyneuropathy. Let us start with mode of onset. So, depending on mode of onset, it is classified as acute, subacute, and chronic. Acute means it is active process of inflammation that is still going on. Subacute means inflammation is resolving gradually. Chronic means now the inflammation has subsided but the damage is permanent, so it will be lifetime. Now based on functional disturbance, so motor, sensory, autonomic and mix. So which clinical features they are present in your patient, like they have motor weakness, sensory disturbances, autonomic dysfunction, or it is mixed. Clear? Based on that there will be classification. Now based on pathological process, so that is axonal and demyelinating. Now you can imagine the nerve. So damage will be in two ways. Either the number of axons will be lost or the number of axons will be remaining same, but the myelin sheath will be having problem. Clear? So if the number of axons they are reduced, or if there is any damage to axon, so that will be known as axonal type of polyneuropathy. And if the myelin sheath is affected, so it is known as demyelinating type of polyneuropathy. Now based on causation, that is nothing but etiology. So if the infection is the cause, it is known as infectious polyneuropathy. If it is carcinoma, okay, generally few polyneuropathies they are associated with sarcoma, lung carcinoma. Sometimes it is this Hawking's disease or lymphoma. Okay, so all these are examples of carcinomatous polyneuropathy. Definitely if it is associated with diabetes, okay, it is diabetic neuropathy. Sometimes it is related to inflammation in body like rheumatoid arthritis. Okay, so that is one type of the inflammation. So if the neuropathy is associated with any this type of the inflammatory process, it is known as inflammatory polyneuropathy, like systemic lupus erythematosus. So all these are inflammatory processes in the body that may affect our nervous system. And vascular, so that is nothing but vasculitis may lead to polyneuropathy because the blood supply to nerves will be lost gradually. Based on distribution, so that is also classified by two ways, whether the polyneuropathy is symmetrical or asymmetrical. Symmetrical means it is same on right as well as left side. For example, Guillain-Barré syndrome, so that is the best example of symmetrical polyneuropathy. And asymmetrical means it is multifocal mononeuropathy, like my right side may be having median nerve affection, left side may not be having. Clear? So it is asymmetrical. Then other type is proximal as well as distal. So if the neuropathy is affecting proximal joints more, it is known as proximal neuropathy, and if it is affecting distal joints more, it is known as distal neuropathy. Okay, proximal polyneuropathy examples are brachial plexus injury or brachial plexus inflammation. Okay, so generally it is known as brachial neuritis. Clear? So that is best example of proximal polyneuropathy, brachial neuritis. Okay, and sometimes it starts with distal joints also, like initially the interossei and lumbricals and all these muscles will be affected more. Okay, for example, diabetic neuropathy, so the symptoms will be more on distal side. Clear? So all these are distribution of this polyneuropathy. Now, the symptoms and signs, those will be classified under two, that is positive sign and negative sign, or positive phenomena and negative phenomena. So what are they? So negative phenomena means it is absence of normal behavior, and positive phenomena means it is presence of abnormal behavior. Now you see properly whether it is absence of normal behavior or presence of abnormal behavior, both are abnormal only. So in case of negative phenomena, we can say that behavior is reduced, and in case of positive phenomena, we can say that behavior is increased. Okay, so whenever any system is behaving in such a way that it is functioning less, so that will be negative phenomena, and if any system is functioning more, it is known as positive phenomena. Now here don't get confused that positive phenomena it is good, okay, or it is good sign of recovery. It's not like that. Negative phenomena and positive phenomena both are abnormal. Now, which are these negative phenomena? So loss of sensation, definitely our nervous system that will be responsible for giving sensation. So if there is damage to our nervous system, definitely the patient will be having either hypoesthesia, and in severe cases patient may develop anesthesia also. Now, whenever the disease is of large myelinated fibers, so there will be loss of touch and joint position perception, and patients may complain in differentiating or discriminating texture with closed eyes. So whenever you give something like silky material or rough material into the patient's hand, so it will be difficult for the patient to feel exact texture. Clear? And their hands and feet feel like they are on cotton wool. Why? Because of lack of this joint position perception. They are not having proper stimulus that is coming from ground or that is from any surface which the hand touches. Clear? So they will be getting very less intensity type of sensation in terms of joint position perception. Clear? So as they are not getting strong stimulus for this joint position perception, they will be feeling that they are walking on cotton wool or they are walking on any soft surface. Why? Because we are getting less stimulus, okay, from the ground if we are suffering from this joint position perception problem. Now, gait is unsteady. Why? Again the problem is same, dysfunction of joint position perception. Clear? So this patients, they will not be able to identify the exact joint position. Whenever we are walking, we don't need to see at the floor, okay, because we know that my foot is on the ground, my foot is off the ground. But these people, they have difficulty to identify that when the foot is on the ground and when the foot is off the ground. Okay, so the gait will be unsteady, especially whenever they are walking in darkness. Clear? Because generally these people, they compensate with vision. So whenever they are walking, they will walk at the floor because the proprioceptions, they are affected. So visual system will be working as compensatory mechanism. Without watching at floor, they will not be having good confidence to walk. Clear? So they will be continuously watching on the floor. Now, if the eyes are closed or if there is darkness, so definitely whatever the compensation was received from visual system, okay, for this affection of joint position sense proprioception, that is lost. So actually patient relies on visual system, okay, as patient has affection in proprioception, but now the visual system is also blocked. So in case of this, patient will be having unsteady gait. Sometimes patient may fall also. Then if the small myelinated fibers they are affected, there will be loss of pain and temperature. So that is nothing but function of spinothalamic tract. So if the pain is lost, we know that pain, we don't like pain, but actually the pain is one type of the alarming mechanism. Okay, what is pain? It is unpleasant and emotional sensory experience. Clear? So whenever we have pain, for example, if I have pain in my knee joint, so I will take care of my knee joint more. I will not band it, okay, I will not walk more. So what I'm doing, I'm not increasing the inflammation in my knee joint. Why? Because the pain gave me alarming sign that you need to take care of your knee. Clear? But if I don't have pain, definitely I will be overusing my knee and I will be damaging to my knee joint. Clear? So pain, if it is present, okay, definitely we don't like it. But if the pain perception, if it is totally lost, then definitely it may result into painless burns or painless trauma. Clear? So that will be more dangerous as compared to pain. Now, damage to joints without pain may result, okay, as we discussed. So that is known as Charcot's joint. So Charcot's joint, it is painless swelling of joint. Clear? Now positive phenomena means behavior is increased, okay, that is presence of abnormal behavior. So disease of large myelinated fibers, they give a sensation of paresthesia. What is paresthesia? So that is nothing but sensation of pins and needles. So the patient will be continuously feeling that someone is giving injury with pin or needles. Clear? As if someone is continuously touching with pin or needles. Clear? Now, disease of small unmyelinated fibers, they will be giving painful positive phenomena. So that will be any type of the sensation will be perceived as pain. So that is again not comfortable for your patient, and patient will be continuously distracted towards that sensation. Now there are different terminologies to learn. Okay, so let us learn one by one. First is analgesia. You all remember this because we are frequently using a word analgesic for the painkiller drug. So analgesia means it is absent sensitivity to painful stimulus. I repeat, analgesia means absent sensitivity to pain stimulus. So we are not feeling any type of the pain. Now hyperalgesia. So the name itself, it is telling hyper means excessive. So it is increased sensitivity to painful stimulus. Hyperalgesia means it is increased sensitivity to painful stimulus. Then comes hypoalgesia. So hypo means reduced. Okay. So hypoalgesia means reduced sensitivity to painful stimulus. Okay. Hypoalgesia, I repeat, reduced sensitivity to painful stimulus. Then hyperesthesia, so that is increased sensitivity to any stimulus. Okay, so esthesia means it is sensation, hyper means it is excessive. So I repeat, hyperesthesia means it is increased sensitivity to any stimulus. Exactly opposite, it is hypoesthesia, that is reduced sensitivity to any stimulus. I repeat, hypoesthesia means it is reduced sensitivity to any stimulus. Now hyperpathia. So it is increased sensitivity with increasing threshold to repetitive stimulation. Okay. So I repeat, hyper means excessive. Okay. So it is increased sensitivity with increased threshold to repetitive stimulus. So if one stimulus is given repeatedly, so definitely the threshold will increase for that, and ultimately there will be development of hyperpathia. Now very discomfortable sensation, that is allodynia. So allodynia means it is pain provoked by non-painful stimulus. So even if you touch the patient anywhere, patient will be feeling pain. Okay, so that is discomfortable sensation. I repeat, allodynia means it is pain provoked by non-painful stimulus. Now symptoms. Symptoms means whatever the patient is complaining. Okay, so which are the motor symptoms? So whenever this weakness is over the distal aspect, so there will be difficulty in clearing the curb when walking. Curb means it is type of obstacle generally found at the doorstep. Clear? So definitely there will be weakness or difficulty in dorsiflexion. So it will be difficult to cross the curb. Whenever the weakness is present proximally, so definitely there will be problem in climbing stairs. Okay, and if we think of the upper limb, the shoulder will be affected. So to comb the hair, we need overhead movement of the shoulder. Clear? So if the overhead movement of shoulder is affected, definitely you will be having difficulty in combing hair, or you will be having difficulty in dressing yourself. Clear? So based on distal or proximal, patient will be complaining differently. Cramps may be troublesome. Cramps means it is one type of the involuntary contraction. Okay, so generally it is found more in calf region, and generally it is more in the patients having tightness of the muscle. So here also cramps will be there. So there is sustained involuntary contraction that will be very difficult to relax. Then twitching of the muscle, so that is known as fasciculation. Fasciculation, it is nothing but involuntary contraction of fascicles. Fascicles means it is nothing but group of muscle fibers surrounded by one common sheath, okay, that is known as endomysium. So whatever the muscle fibers, they are covered with endomysium sheath, okay, collectively that unit is known as fascicle, and the involuntary contraction of this fascicle, it is known as fasciculation. Now, signs means what you have to check on your patient. So you have to check superficial sensation in terms of fine touch. Fine touch you can check with a wisp of cotton, okay, or simply with your finger also. Crude touch, that you need to check with hair aesthesiometer or with gentle pressure with your finger. Then thermal sensation we need to check. So that is to be checked with two test tubes. One test tube will be filled with the cold water having temperature of 5 to 10 degrees Celsius, and one test tube will be filled with the hot water. So the temperature for hot water ranges from 40 degrees Celsius to 45 degrees Celsius. And last is pin prick. So that will be used by end of the pin, but here the pin should be used only one time, then it should be thrown. And before you test on the patient, you should sterilize the end part or tip part of this pin. Clear? And whenever you are checking all the sensations, patient's eyes must be closed. Patient's eyes must be closed whenever you are checking this sensation. And in your patient's body, if any part is normal, like if the patient has face that is not affected, clear, so you should compare your sensation with face, clear, like you are checking on lower limb and you are checking on face also simultaneously, and you are asking your patient whether you are feeling same or one is more as compared to other. So we can also identify that as compared to normal part, the sensations, they are reduced or not. Then coming to deep sensation, so that includes joint position, joint movement and vibration. So by different position of the joint, okay, we can check the joint position and joint movement. Clear? So either you put patient's joint into particular position and ask the patient to perform the same thing on opposite side. Okay, so that is joint position. In the similar way, you can check for joint movement also, like whether you are going from extension to flexion, okay, and you ask your patient that opposite limb also you move, okay, from extension to flexion, whatever, from flexion to extension or from extension to flexion, whatever. Clear? So in joint position, patient will have to mimic the joint position, okay. In joint movement, patient will have to perform the same movement. Clear? And vibration, so vibration is checked over the bony prominences, generally with the tuning fork of frequency of 512 hertz. Clear? So that is vibration. Now which are the signs for sensory? So we have to check, sign means we are checking, okay. Sensory ataxia we have to check with Romberg sign. So in Romberg sign, we all know that patient will be in standing position for 30 seconds, okay. Initially with eyes open, you observe that patient is swaying or not. If the patient is swaying, no need to check the second step, but if the patient is stable with eyes open, then you proceed to second step, ask your patient to close the eyes. Clear? And that should be maintained for 30 seconds. So if the patient is not able to maintain his balance with eyes closed, so you can say that Romberg sign is positive. Okay, what is the clinical significance behind this? So for example, if your patient is suffering from sensory ataxia, means the joint position, joint movement, they are lost. In short, we can say that proprioceptions, they are lost. So if the proprioceptions, they are lost, patient will be dependent on visual system. So patient doesn't know that my ankle is in plantar flexion, neutral or dorsiflexion. They don't know whether the knee is in flexion or extension. Clear? So what they are doing, they are relying on their vision. Now when you block the vision, so ultimately patient is not getting any feedback regarding his or her joints, okay, because the vision is blocked. So patient will not be able to maintain balance. There are chances that patient may fall also. So whenever you check Romberg sign, you should be near to the patient in such a way that if the patient sways or if the patient falls, you should be able to prevent the fall. Clear? And by gait examination, so generally if the patient is having proprioception problem, so patient will be walking with the stamping gait. Stamping means when the patient puts his or her foot on the ground, Okay, he or she does vigorously, as if you are stamping on paper. Clear? So this is how stamping gait occurs. Why? Because they are putting their limb in such a way that as if it is falling. Why? Because it gives greater stimulus. Clear? So that they will be able to feel some amount of this proprioception. Clear? So they need to stimulate their proprioception with greater intensity. That's why they are stamping. And whenever they walk, they will always look at the floor. Okay, without seeing at the floor, they will not be able to walk properly. So these things we have to see in gait examination. Now trophic changes, so that is nothing but skin related changes. So the extremities will be cold and blue. Okay, and most of the hairs will be lost. Clear? And there will be brittle finger or toenail. So that will be occasional finding, not always. So by checking nails also of finger or toe, you will be able to identify few trophic changes. Then axon reflex. So axon reflex, it is the reflex where the impulse is going away from the cell body to produce some action, like it is responsible for vasodilation in all the population. In case of asthma, it will be responsible for stimulation of production of few neuropeptides. Clear? So all these are reflexes, example of axon reflexes. Clear? Now, which are the signs of motor? So we have to check for the muscle wasting. Generally, the muscle wasting will be more evident in case of axonal neuropathy as compared to demyelinating neuropathy. And generally, it is seen in first dorsal introsi, okay, that is in upper limb, and in lower limb, they will be seen in extensor digitorum brevis. Clear? So in upper limb, small intrinsic muscles, they are affected, and in lower limb also EDB, that is extensor digitorum brevis, those will be first to get affection. Now you will be having fasciculation. So as we know, fasciculation means it is involuntary contraction of fascicles. Fascicles means one fascicle means it is the group of the muscle fiber surrounded by single endomysium. Clear? So that is nothing but one unit. So if fascicle is having involuntary contraction because of continuous firing of this nerves, so it will be known as fasciculation. You will be having muscle weakness, so that you can grade with your muscle charting. Now, generally in case of AIDP, that is acute inflammatory demyelinating polyneuropathy, or in case of CIDP, that is chronic inflammatory demyelinating polyneuropathy, proximal muscle weakness will be seen. So again, these patients will be having more problem in climbing steps because of lower limb weakness and overhead activity like combing hair, dressing in case of upper limb weakness. AIDP, that is acute inflammatory demyelinating polyneuropathy, it is nothing but Guillain-Barre syndrome. Clear? Okay, CIDP means the existing clinical features, they will be existing more than 8 weeks, and generally they will be lifetime. Now, in case of severe neuropathies, you may be having muscle weakness of your trunk as well as respiratory muscle weakness. So that will be life threatening, and many times the patient needs ventilatory support in ICU, especially when they are suffering from respiratory muscle weakness. Now, investigation. So there is one guideline. If the etiology is known, so definitely you will be able to identify the neuropathy very easily. For example, if patient has distal symmetrical sensory motor polyneuropathy and patient is also suffering from diabetes, so it is nothing but diabetic polyneuropathy. Okay, let us understand with another example. If the patient is having distal symmetrical sensory polyneuropathy and patient is also giving you history of alcoholism, means patient is consuming alcohol on daily basis. Clear? So it is nothing but alcoholic polyneuropathy. You can also tell this as toxic neuropathy. Clear? Because you have toxin, that is nothing but alcohol, that is damaging your nervous system. So it is alcoholic polyneuropathy. Now, if etiology is unknown, so in that case, how to proceed? So you take history from the patient as well as clinically you assess pattern of neuropathy. So based on history and pattern of neuropathy, it will guide us to select the proper investigation. Now, which are the initial investigations? So they are, first is blood glucose, so that will be useful to diagnose the diabetes. Second is HbA1c, so that is nothing but glycated hemoglobin, so that will be again supporting diagnosis of diabetes. Urea, so that is nothing but testing kidney functions. Electrolytes, sodium, potassium, chloride, all this can be tested into this serum. Okay, and if they are abnormal, definitely they will affect the function of nervous system. Then liver function test in form of SGPT and SGOT. Then thyroid to identify whether it is hyperthyroidism or hypothyroidism. Then protein electrophoresis, so it is one of the process that identifies or measures the exact amount of protein into the blood. ESR, that is erythrocyte sedimentation rate or plasma viscosity. So if the ESR is raised, so definitely it is suggestive of some inflammatory or infective process into the body. Then vitamin B12 and folate, so deficiency of this will be affecting the function of nervous system. Out of this vitamin B12 deficiency, that is very common especially in vegetarian people, so they are suffering from polyneuropathy. It is also known as nutritional deficiency type of polyneuropathy. And chest x-ray to identify other inflammatory process in the body. Then further investigations based on patient's clinical history. So that is glucose tolerance test, so that is nothing but body's response to glucose. So again, if the patient is having type 2 diabetes, this glucose tolerance test will be helpful. Then presence of this antibodies like autoantibodies, rheumatic factor, NCA. NCA means it is anti-neutrophil cytoplasmic antibody. Then tissue transglutaminase antibodies. We know that whenever there is infection, so antibodies will be produced. So if by test the physician is finding that there is presence of antibodies into the blood, it means you have infection. Okay, so it is very simple. Antibodies will be seen into the blood only when you have infection. So presence of all those antibodies, they will be suggestive of inflammatory or infective process. Then angiotensin converting enzyme level, so that will be responsible for maintenance of blood pressure. Any abnormality of this level will lead to problem of blood pressure. Then anti-neuronal antibodies, then anti-ganglioside antibodies, anti-myelin associated glycoprotein antibodies, that is anti-MAG. All these are found in blood whenever you have infection or inflammation. Now genetic study will be also done if you suspect any polyneuropathy as like hereditary, if you suspect, clear. So in that case clinical examination will be also done of relatives, because it is possible that, for example, if it is hereditary, okay, so genetic test of particular patient will be definitely done, but patient's brother and sisters, they are also examined, okay, to identify the disease earlier. So the clinical examination as well as genetic studies will be done of relatives also along with patient. Then porphyria. So what is porphyria? So it is one type of the group of disease in which substance called porphyrin, okay, it will build up and it will be negatively affecting the skin and nervous system. So you can say that porphyria, it is a disorder of skin and nervous system. Now HIV, so that is human immunodeficiency virus. We all know HIV because of awareness regarding this HIV done by government. So HIV itself, infection itself, it is neurotoxic, as well as whatever the medicine is used for treatment of HIV, so that is antiretroviral therapy, ART, so that is also neurotoxic. So disease itself as well as treatment in form of medication, both are neurotoxic. Then CSF studies, so generally protein and different cells, okay, different antibodies, okay, glucose level, all this will be checked in CSF, because most of the time whenever you have any problem in central nervous system, you will be having elevated protein level inside your CSF. Then you have to screen for primary tumor also, because tumor should be excluded or ruled out properly, because tumor may also be a reason or cause of your weakness. Okay, so for that go for CT scan or PET scanning. PET means it is positron emission tomography, so that is one type of the functional analysis of brain, clear. So based on the blood supply to different tissues of brain, okay, they will be assessing the abnormality. So PET scan will show you that if any part of the brain is not getting proper blood supply, so it may not be functioning well. Now, asymmetrical or multifocal neuropathies, so they are less common, and there are usually clues in the history to direct the investigation towards what is most frequently an underlying inflammatory disease. Okay, what it is telling, for example, if the patient is having vasculitis or specific inflammatory neuropathy, so these are less common and generally they are asymmetrical or multifocal. Multifocal means at different places they will be having different affection. Clear? Like right median nerve may be affected, but left median nerve may not be affected. Clear? Okay, at the same time left ulnar nerve may be affected, so it is multifocal neuropathy. Clear? Now, in this case also, you can also take help of inflammatory markers or antibodies, because if the infection or inflammation occurs, there will be presence of antibodies and some inflammatory markers into the body. Now, in such patient, nerve conduction study and nerve biopsy will be required as specific diagnosis. Now, nerve conduction study. So how it is helpful? So it will be useful to determine the type and distribution of pathology. So as I told, right median nerve may be affected, left median nerve may not be affected, but left ulnar nerve may be affected also. Clear? So how the affection is distributed into the body, that we will be able to identify. Then whether the patient is having axonal or demyelinating type of polyneuropathy. So axonal means your number of axons will be less, okay, as compared to normal now. So that will be identified by reduced amplitude of compound motor action potential or sensory nerve action potential. So in nerve conduction study, amplitude will be less, okay, and demyelinating. So there is nothing but it is process of myelin sheath degeneration. So it will be identified by prolonged latency or reduced velocity in nerve conduction studies. Now, to demonstrate asymmetrical involvement, so whenever you are doing this nerve conduction velocity, so you are separately checking each nerve on each region. Clear? So definitely whether it is symmetrical involvement or asymmetrical involvement, you can identify easily by this nerve conduction study. Then you will be also able to demonstrate conduction block or focal demyelination. So conduction block means the impulse distal to this block, it is passing properly, but whenever it is coming from proximal side, so it will be very difficult for that impulse to cross this block. Clear? For example, carpal tunnel syndrome. Okay, so if the patient is suffering from carpal tunnel syndrome, so distal to compression nerve conduction is normal, but when you stimulate proximally and record distally, conduction block will be found. Okay, so area of focal demyelination you can also identify by different techniques in nerve conduction velocity. Now biopsy. Biopsy means the tissue will be taken and it will be examined. So it will be aiding the diagnosis in asymmetrical multiple mononeuropathies, like in case of vasculitis, amyloidosis, sarcoidosis. Okay. Now, generally, which nerve will be taken for biopsy? So, generally, the sural nerve will be taken. Why? Because if the sural nerve is getting damaged for this biopsy procedure, it is not having any motor supply. It is purely sensory nerve, and that is also on the lateral aspect of foot. So, in case if that sural nerve is compromised, okay, so the impairment, functional impairment will be minimal. Now, physiotherapy management. So first of all, we need to focus on chest physiotherapy, especially if the patient is bedridden. Clear? So chest physiotherapy includes percussion, vibration, shaking, nebulization, postural drainage, and periodic suction. Clear? So we all are familiar with this particular techniques. Okay, so we have to work on patient's chest hygiene. Okay, if the patient is conscious and patient is cooperative, definitely you go for breathing exercise. Okay, then you think for diaphragmatic breathing, you go for segmental breathing, depending on patient's requirement and patient's cooperative behavior. Then maintenance of range of motion. So for that, you know that what to do. So you go for passive range of motion exercise, as well as you also can help the you can also take help from the splints also, because splints will also maintain particular joint into particular position, so it will prevent the contracture and tightness. So definitely if the contracture and tightness they are prevented, range of motion will be maintained. Then support to the limbs. So positioning of the patient should be such that it is totally supported by any surface. It may be bed, or it may be wheelchair, or it may be simple any sofa also. Okay, so you should teach the patient the supporting positions of particular limbs, because they are already weak. Now pain relief. So as we discussed, there may be paresthesia or burning type of the sensation. So if the patient is complaining of this, we can think of TENS, transcutaneous electrical nerve stimulation. Okay, it is not curing the nerve, but at least it is giving some temporary relief from the pain to the patient. Maintenance of the muscle properties. So we are already giving passive movement, but in case if the atrophy is more profound, you can also think of electrical stimulation in form of intermittent galvanic current to maintain the muscle properties. But if the patient is able to perform active movements, better you go with active movements rather than electrical stimulation. But if patient is like not doing active movement, so in that case, for muscle property maintenance, you can think of ES, that is electrical stimulation. Then prevention and treatment of pressure sores. So as the patient is in prolonged sitting position or prolonged lying position, in that case patient may develop pressure sores over the bony prominences. So in that case, you design the protocol in such a way that patient should be changing his or her position frequently, at least at every 90 to 120 minutes. If the patient is not able to do voluntarily, you can do it, okay, or teach the relatives. Clear? And bed sheet should be also very straight without any crease. Abundant amount of powder should be utilized. Okay, there should not be any type of the pressure generating like any material that causes pressure over the skin, that should not be used, or that should not be put over the bed. Better you think of water bed or air bed. Clear? So all these are possible remedies to prevent the pressure sores, because if the pressure sores occurs, then it will be very difficult to manage the patient. Clear? So prevention is better than cure in case of pressure sores. You can also give powder, because if the skin is wet, there are more chances of getting pressure sore, so use powder. Then prevention of postural hypotension. So the name itself, it is telling, whenever the patient is changing posture, there are chances of development of giddiness, faintness, okay, or darkness in front of the eyes. So why this is happening? Because when the patient is in lying position, so heart is pumping the blood into the horizontal direction. But whenever the patient comes into standing position or sitting position from the lying, so heart will have to pump the blood against gravity. Clear? So it may take some time, because autonomic nervous system is impaired here. Okay, in few cases, not in all cases. So here the patient, when he comes from lying to sitting or standing position, he may develop postural hypotension. So blood is reaching to brain, that is less in amount, so that will lead to problem. Okay, patient may feel faintness or giddiness. Then patient needs psychological support, because the patient is becoming more and more disabled day by day. So patient's counseling is very important to win the confidence of the patient. That is very important, so that patient adheres to our protocol of physiotherapy management. Then strengthening exercise. So as much as it is possible, we should increase the strength of the patient to make the patient more and more functional. Then functional training. So whatever the patient's occupation is there, if possible, we should give that type of the training, so that patient is able to continue his profession, or at least activity of daily life should be taught. Activity of daily life means it is if the patient is able to manage from lying to sitting, from sitting to standing, walking, okay, few simple activities like stepping, okay, so cycling, all these are activity, those will be helpful, okay, for the activity of daily life. So that is nothing but functional training that we should give to the patient based on patient's requirement. The functional training should be always designed based on patient's requirement. And gait training, so gait is very important to maintain the mobility. Just imagine yourself that if you are not able to walk, okay, or if you are intentionally made in sitting position for 4 hours or 8 hours when you are traveling by train or you are traveling by air, okay, so we cannot maintain, or we don't like to sit in one position for more than 2 hours or 4 hours. How these people will like to remain permanently into the sitting position or lying position. So as much as if it is possible, gait training should be given. Okay, if the patient is not able to walk without any assistive device, you can think of giving assistive device also, like walker or can or anything. Yeah, so gait training is very essential to maintain the ambulation of patient. This lecture is prepared from Neurology and Neurosurgery by Lindsay and Physiotherapy in Neurocondition by Glady Samuel Raj. So if you have any question, you can ask. Thank you.